Hello, everyone. I'm Dr. Damilaido Ellsworth, and this is the SPY review session talking about alcohols, cleaning, and chemical substances. So the contents we'll be covering during this lecture include some toxic alcohols that are must know for your exam, including methanol, ethanol, ethylene glycol, isopropanol, and some glycol ethers. And then we will also be talking about some cleaning and chemical substances that also will tend to come up on your exam. And so the first thing we want to establish here is what makes a substance an alcohol. And so an alcohol basically refers to a compound that's typically, maybe a hydrocarbon of some kind, but a carbon molecule connected to this specific functional group that's an oxygen and a hydrogen bonded together. So it's that hydroxyl functional group, and that's what makes a substance an alcohol. But it's going to matter where that connection happens. But all alcohols have certain things in common. One is that they're all intoxicating. And so there's going to be some mental status changes associated with consuming an alcohol. All alcohols will cause an elevation in your serum osmolality. And so you will see an elevated serum osmolar gap. Um, Alcohols are metabolized in the body by enzymes called alcohol dehydrogenases, which we're going to talk more about. That ends up being very important. And then some alcohols form metabolites that will actually lead to an anion gap metabolic acidosis. And that's how some of the alcohols that we will be talking about cause their toxicity. Some alcohols, instead of forming an anion gap metabolic acidosis, actually make metabolites that are ketones, and so lead to ketones in the urine as opposed to metabolic acidosis. As you know, this is relevant to our talk today. Some alcohols form metabolites that have very specific end organ toxicity that we would need to be aware of. And so here's an alcohol. But like I mentioned, where that connection is happening actually matters. And so whenever we have an alcohol where the R group, which is a carbon, is connected to just one other carbon, that is called a primary alcohol. And so primary alcohol will go ahead and be metabolized by alcohol dehydrogenase and then ultimately aldehyde dehydrogenase and will form a carboxylic acid, which is an acid. So you'd expect a primary alcohol to potentially lead to an anion gap metabolic acidosis due to the formation of this carboxylic acid. A secondary alcohol is connected to two other carbon groups, and so that makes it a secondary alcohol. And a secondary alcohol will be metabolized by alcohol dehydrogenase again, and this will form a ketone. And so this is the alcohol that doesn't necessarily lead to a metabolic acidosis, but does lead to elevated ketones in your serum and ultimately your urine. So what happens if you have a tertiary alcohol? And so that means that my carbon that's connected to the hydroxyl group is connected to three other carbon molecules associated with it. So when you have that, really not much happens. And so for the sake of this lecture, don't really worry about tertiary alcohols. And so now we'll talk about some specific alcohols and the toxicity that are associated with them. And so the most common of all is ethanol. So ethanol is worth talking about here. One, it is the preferred substrate for alcohol dehydrogenase. And so we take advantage of this to potentially use it as an antidote, which we will talk about this more. But we can use it to block alcohol dehydrogenase and prevent the toxic metabolite from those other toxic alcohols that we will be talking about. And so we typically say when someone has a serum ethanol greater than 100 milligrams per deciliter, their alcohol dehydrogenase is essentially blocked. But ethanol has its own toxicity associated with it. You have nausea, vomiting, gastritis. You can have a disulfiram reaction depending on your ADH activity, as well as co-ingesting ethanol with other substances, which can lead to disulfiram reaction. Pancreatitis with a binge drinking episode is a well-known phenomena. And then chronic alcoholism is associated with certain nutritional and electrolyte abnormalities, including hyponatremia, malnutrition, issues with magnesium, potassium, and so forth. In chronic alcoholics, they also tend to have issues with their glucose. Metabolism, and so they tend to be prone to hypoglycemia. The other group that can have hypoglycemia with acute ethanol intoxication are really, really young babies. So it's really important to get a point of care glucose when you're dealing with ethanol intoxication, either with a chronic alcoholic or when you have a really young pediatric patient. And as we know, ethanol is a teratogen, and so fetal alcohol syndrome is a concern, but that typically is a concern when we're talking about more than 5 drinks a day in an expectant mother. And so, as I mentioned, all alcohols will cause an elevation in your serum osmoles. And so, when we do that serum osmol gap equation, which we'll talk about more, it is very important that we remember to factor ethanol in that gap calculation. So that's a common source of error that can lead you to think that someone has a really elevated osm gap and might lead you to attribute it to another toxic alcohol when it's in fact just from their ethanol ingestion. And so we don't really see this anion gap metabolic acidosis with ethanol. And the reasons for that are a little bit beyond the scope of this lecture. And so even though it is a primary alcohol, the ultimate metabolite is consumed in such a way in the body that we don't really typically see this elevated anion gap from acute alcohol ingestion, acute ethanol ingestion. But with chronic ethanol use, it does change your metabolic pathways and your redox potential in the body that leads you to have this issue where you have this chronically elevated lactate. And that can cause you to have a metabolic acidosis. And then chronic alcohol users also are prone to developing something called alcohol ketoacidosis, which is a ketoacidotic state. And so they can also have an elevated anion gap metabolic acidosis from that process. The next alcohol that we'll talk about is methanol. So again, this is another primary alcohol. And so what are some sources of methanol? So methanol, we kind of classically associate with windshield wiper fluid, but you can also see methanol in certain labs. So like a chemistry lab will use methanol as a solvent for things. Methanol can also be found in certain kind of cooking gel, and then also is found in paint remover. Amongst other things. And so lots of sources of methanol. This is one of the more toxic alcohols that exist. And so as mentioned, the primary parent compound, methanol itself, will lead to intoxication and will also lead to gastritis. So it can be pretty irritating to the GI tract. But it will go ahead and be metabolized to formaldehyde and ultimately formic acid. Formic acid will cause a metabolic acidosis and toxicity. And so the toxicity specifically from formic acid has to do with its effect specifically on your electron transport chain, and it has this tendency to target the retina. And so methanol ingestion toxicity will lead to blindness. So that is the big thing that you want to take away from this. So metabolic acidosis, along with some other problems that go along with that, but specifically leading to blindness. Isopropyl alcohol, and so as depicted here from this picture from Goldfrank, so isopropyl alcohol it is a secondary alcohol. And so as a secondary alcohol, it's going to get metabolized to a ketone, specifically acetone in this case, by alcohol dehydrogenase. And so you will not see typically an anion gap metabolic acidosis from isopropyl alcohol by itself. Isopropyl alcohol will instead, as we establish, cause intoxication. And also acetone itself actually has CNS depressant effects. And so that CNS depression that you might see from this will both be from the parent compound as well as the acetone that is produced. In very high doses, you can see some hemodynamic instability, but most commonly, the issue that you see with isopropyl alcohol, colloquially rubbing alcohol, is hemorrhagic gastritis. So again, this significant irritation to the GI tract. Um, the one thing that could come up on your exam is this known phenomenon where it will potentially cause you to have what looks like an elevated creatinine, but this is actually a lab error, and it is because of this interference with the Jaffe reaction. And so potentially you could see a question stem about a patient with an elevated creatinine in a setting of isopropyl alcohol intoxication, and it is not truly an acute kidney injury. It is a lab error. Next alcohol is ethylene glycol. And so as you can see here, ethylene glycol, also known as antifreeze, would kind of commonly have this greenish color to it, which is really unfortunate because that kind of looks like certain flavors of Gatorade. And what people commonly like to do is to store either their windshield wiper fluid or their antifreeze in different containers to make it easy for travel and for storage in their vehicle. And so we have seen cases where people will put ethylene glycol in a Gatorade bottle. And then someone who doesn't realize that this is the case thinks that what they are seeing in the Gatorade bottle is truly Gatorade when it's actually ethylene glycol. And unfortunately, ethylene glycol is actually kind of sweet tasting, which also kind of contributes to this misfortune. But ethylene glycol is a primary alcohol. It's actually kind of two of these hydroxyl group that are kind of on those two end carbons here. And so ethylene glycol, because it's a primary alcohol, will go through these series of reactions and ultimately form these acids that will contribute to your metabolic acidosis. And so the things that contribute to your metabolic acidosis here are your glycolic acid, your glycoxylic acid, and your oxalic acid. And so the other thing with ethylene glycol is that oxalic acid will have this tendency to precipitate with calcium and then settle in your renal tubules. And so one of the things that you see with ethylene glycol toxicity is a profound hypocalcemia as well as renal failure with these stones in the kidney. So, how do we diagnose a toxic alcohol? So, a lot of the pieces to it is history. And so, someone with a prior history of ingesting a toxic alcohol or having an unexplained anion gap metabolic acidosis with, prior ingestion or a tendency to do this or a tendency to drink other alcohols other than ethanol to try to get intoxicated. But whenever we are able to obtain a concentration, it is helpful to do so. This is not always available. It's available in certain hospitals, in certain parts of the country, and then in certain parts of the country, it's just not something that people will be able to obtain. But if you are able to obtain a concentration, I would typically associate a concentration greater than 20 milligrams per deciliter to be toxic when we're talking about ethylene glycol or methanol. But A lot of people are going to find themselves in situations where they cannot obtain a concentration. And so we have to use both the history and clinical clues, as well as other laboratory markers to potentially help us tease this out. And one of the laboratory markers is kind of looking for an unexplained elevated osmolar gap. And so an osmolar gap is basically taking your measured osmolality and taking that and subtracting it from your calculated osmolality. And so the idea here is this osmols is just really a measure of stuff in your serum. And so there is some stuff that you expect to be there, and things that are charged are kind of accounted for with this formula that has to do with your sodium. And so this 2 times sodium will basically account for anything that's charged in your bloodstream. You also expect that there will be glucose. You expect that there will be BUN. And as I mentioned earlier in the lecture, if you know that there's ethanol on board, you also have to factor that in. And so this is a formula that's out there that uses that 4.6 for the ethanol, and then 18 for glucose and BUN 2.8. So it's 2 times your sodium plus glucose over 18 plus BUN over 2.8 plus ethanol over 4.6. And so this is a formula that I have to memorize and rememorize and forget. And so I highly recommend trying your best to memorize this the day before your exam. And then when you are actually taking care of patients clinically, it is totally okay to look this up to remind yourself. But what you're going to do is take that calculated osmolality and then have the lab draw a serum osmolality from the patient. And when there is a gap, so when there is more stuff present than what we know should be there, that could be a clue that there is a toxic alcohol on board. The other piece here is the anion gap. The anion gap, if we are dealing with alcohol that does lead to an elevated anion gap, really tells us that toxic metabolites have already been made. And so this is something that might not be elevated when you first start taking care of the patient if they come pretty soon after their ingestion, but it is something that will increase with time. But the osmolar gap that we just talked about has lots and lots of limitations. One is that the normal range is actually quite large. And so different textbooks, different resources will have different ranges kind of reported, but we think like -2 to 8 is kind of the normal range. And we don't routinely get osmolar gaps on people. And so we actually have no idea what our individual patient that we're taking care of. We have no idea where they started off from. And so there have been reports of patients who had a normal osmolar gap that actually corresponded to a treatable level of a toxic alcohol because that was really not a normal osmolar gap for that patient. The other piece to the osmolar gap is that depending on when the patient presents, the osmolar gap actually gets smaller with time. And so your anion gap gets larger with time, while your osmolar gap decreases in time. And so this is a graphical representation of that. So when a patient first comes in and they have mainly the parent compound has just been absorbed from their GI tract. So most of the stuff that's in their bloodstream is the parent compound. The parent compound is the thing that's contributing to the osmolar gap. So at the very early end of toxicity, the osmolar gap is really high. But as the parent compound gets metabolized to your toxic metabolites, which are the things that contribute to the anion gap, those anion gap contributing metabolites are actually charged. And so because they are charged, they are actually accounted for in that formula by the sodium, like we talked about And so because of that, your osmolar gap will get smaller as you make more and more toxic metabolites. But as we already established, the toxic metabolites are acids. They're going to cause you to have an elevated anion gap. So that will get higher and higher. It's really unfortunate if patients were to come in this weird window where the osmolar gap is relatively low, but the anion gap isn't quite high to the point of raising alarms. And so those patients can really fall into this crack and potentially be missed. And so that's why it's really important that clinical history that we talked about, and then getting kind of serial labs in a setting where we are unable to obtain that alcohol concentration. Other labs are going to be important as we're kind of doing our diagnosis evaluation of these patients. As we've established, it's really important that we actually know what their ethanol concentration is. So one is that we need to factor it in if we are going to be using the osmolar gap. And the second piece is that we know that an ethanol greater than 100 milligrams per deciliter means that your ADH is blocked. And so you really shouldn't be making toxic metabolite if you have co-ingested enough ethanol with the toxic alcohol. Other labs that are helpful, your electrolytes, your kidney function, and so forth, because as we know, some of these alcohols can lead to profound electrolyte derangement and kidney injury. And so now we'll talk about treatment. So we always talk about the different tenets of treating a tox patient. The first step is typically thinking about GI decontamination. Unfortunately, for alcohols, a lot of your GI decontamination strategies don't really make sense here. Namely, charcoal doesn't really make sense. These alcohols get absorbed so quickly, so we are typically not reaching for charcoal or really any of our other GI decontamination strategies in these cases. We are doing a lot of supportive care for all of our different kinds of alcohols, specifically for ethanol and isopropyl alcohol. Most likely, all these patients will need is supportive care and time, some fluids, some antiemetics, and so forth. But when it comes to our other toxic alcohols, we do want to maybe think about some targeted therapy. And so when we talk about targeted therapy here, we are really talking about blocking of alcohol dehydrogenase. And so as I mentioned before, ethanol works, but ethanol is a really, really tricky antidote to use. It was used historically, but we have a better ADH blocker, which is fomepizole, that is easier and safer to use. So fomepizole is going to be the answer on your test when it comes to the treatment to reach for. We can also think about enhanced elimination. So enhanced elimination here, speaking of specifically, is dialysis. And so dialysis is going to be helpful for both clearing the parent compound as well as the toxic metabolite. And so when a metabolic acidosis is present, that tells us that we've already made toxic metabolites. And so if we know that we've already made toxic metabolites, we know that giving fomepizole will only prevent the formation of more toxic metabolites, but the fomepizole or the ethanol will not do anything for the toxic metabolites that have already been made. And as we mentioned, the issue here is not just the metabolic acidosis that you get with these metabolites, it's that they have other end organ issues that they cause, so blindness, kidney injury, strokes, and so forth. And so when you have a metabolic acidosis, you have to figure out a way to clear the toxic metabolite. And really the only way to do this is going to be dialysis. And so this is an indication for hemodialysis. Other things that can also be considered are some supplemental treatments that can be used. And so we will give things like thiamine and folate, and that is because they facilitate the conversion of some of our toxic metabolites to less toxic metabolites. So for ethylene glycol, we reach for thiamine and pyridoxine, and for methanol, we reach for folate, which will encourage the transformation to slightly less toxic metabolites. So there are other glycols that exist that we don't tend to talk as much about, but may come up on your exam. So that includes propylene glycol, diethylene glycol, polyethylene glycol, as well as these other alkyl ethers of ethylene glycol. So propylene glycol, this can be found in as a diluent for certain medications, IV medications that are sometimes used in a hospital, such as lorazepam, and then certain antifreeze that are actually called pet-friendly antifreeze, for example, are used propylene glycol as opposed to ethylene glycol. So what you need to know about propylene glycol is that this will be metabolized to lactate. And so propylene glycol will lead to an elevated lactate with this metabolic acidosis. And so propylene glycol, elevated lactate. That's the thing to know about it. Diethylene glycol is another one that is worth knowing about. Diethylene glycol is interesting because it has also been used inappropriately as a diluent in a medication and has been responsible for a lot of mass poisonings throughout history, including one here in the United States. That mass poisoning of an antibiotic, sulfonamide, actually ultimately led to the formation of the FDA. Um, but diethylene glycol is suspected that both the parent compound and the metabolites have end organ dysfunction associated with them. And so, as I mentioned, a lot of historical mass poisonings have happened with this. What's known to be associated with diethylene glycol include renal failure and some CNS abnormalities. It can lead to a coma. There has been mortality associated with it. And it has this classic association with neuropathy, specifically a cranial nerve neuropathy. And so it has been shown to have to cause bilateral cranial nerve 7 palsy. And so that's what this kind of looks like. So you have bilateral facial weakness. Because both the parent compound and the metabolites tend to be pretty toxic, this is one where you're actually reaching for dialysis pretty early on. That is kind of the preferred treatment for this. Can think about fomepizole, but you want to think about dialysis pretty early. Polyethylene glycols. So polyethylene glycols you probably know as Miralax, and that is your high molecular weight polyethylene glycol. And so because it's a high molecular weight polyethylene glycol, it's not really absorbed that well from the GI tract, and that's why it works really well as an osmotic laxative. But there are low molecular weight polyethylene glycols, and these ones do get absorbed, and they can cause significant toxicity, including CNS depression, metabolic acidosis, renal failure. Generally rare, we don't really come across these that often. And so because of that, we know a little bit less about them. But just remember that there's a difference between high molecular weight and low molecular weight polyethylene glycols. And then you have your alkyl ethers of ethylene glycol. This is another one. They're industrial chemicals. They also can are used very commonly as solvents. They're in certain household cleaning products and window cleaning products. We have limited knowledge of their toxicity because of how infrequently we come across these. But things that have been reported with prior exposures and ingestions include coma, hypotension, multi-organ effects like hemolysis, metabolic acidosis, and kidney injury. Okay, so now is a good time to take a break because that was a lot to take in because we're going to kind of pivot a little bit and now just talk about specific household cleaning chemicals that are worth knowing for your exam. So some other toxic household chemicals. So that today we're going to be talking about hydrogen peroxide, selenious acid, iodine, pine oil, phenol, and certain detergents and laundry products. So hydrogen peroxide is interesting. It's used as a disinfectant. There are different concentrations that you're going to come across, and we really, really worry about the high concentration of 35% that would be in certain industrial grade hydrogen peroxide. So hydrogen peroxide is both a concern from a local injury perspective. So it will cause local caustic injury. So if you ingest it, it's both a caustic, but also what it does systemically is also pretty scary because as it gets into your GI tract, it will interact with enzymes in your GI tract and basically lead to the liberation of oxygen, and that can travel through your GI tract and ultimately lead to air embolism that can really go anywhere in the body and cause different issues like strokes, heart attack, and stuff like that. So when we are dealing with that high concentration hydrogen peroxide, that 35%, just one cc of that 35% will liberate 100 mLs of oxygen. So you can imagine drinking 10 mLs of that. And so when this happens, when you see evidence of air emboli, typically starting with some portal venous gas, the treatment for this is hyperbaric oxygen. The next substance that we'll be talking about is selenious acid, also known as gun blowing solution. And so this causes acute selenium poisoning, which can be fatal. There has been a fatality reported in a young toddler with a dose as small as 15 ml in a 4% solution. Um, what is associated with this classically is this garlic odor, but it causes GI distress and multi-organ system failure with circulatory shock. So this is one where treatment is unfortunately just supportive. We don't really, even though selenium is a metal, we really don't think about chelation in these because there's just no evidence that it works that well, and there might be some evidence that it might worsen toxicity. Iodine. Iodine has antiseptic properties, and that's why we tend to use it. Depending on the form of iodine that you're working with, your toxicity might be more or less severe. So liquid iodine, like Lugol solution, will tend to be more toxic than something like betadine, which is called an iodophore, which is iodine connected to some carrier molecule. In this case of betadine, is providone. So iodophores tend to be less toxic than just the pure liquid iodine. So iodine is also a concern because it causes caustic injury, but it's associated with some concerning systemic toxicity as well, namely kidney injury. You can have some allergic reactions. Iodine is interesting because certain assays will misread iodine as chlorine, and so can lead to elevated chlorine in your blood work, which again is a lab error. With chronic exposure, you can have thyroid dysfunction. And so, how you would treat iodine toxicity, again, namely supportive. There is maybe a role for sodium thiosulfate, which may convert the iodine to a less toxic form. And then this is one where, in some cases, hemodialysis has been used. Pine oil is another one to be aware of. It's a household cleaner. It is a volatile hydrocarbon, and the hydrocarbons here are terpenes. And so what happens is that you get GI distress from drinking this hydrocarbon. But as we know about hydrocarbons, one of the problems with them is their tendency to cause pretty severe pneumonitis. And so that is one of the issues with pine oil is this respiratory failure that you get and severe ARDS that you can get from ingestion. Also has CNS depressant effect, so you get mental status changes. And there have been cases that have been fatal. Phenol is one that was used historically as a germicidal agent, but it's still found in pretty low concentrations in certain ointments, disinfectants like Creolin, gargles, and deodorizers. And so you could still come across this from someone drinking enough of it. One thing to know about phenol is that it is very, very well absorbed through the skin. And so there's rapid dermal absorption. So it causes toxicity by leading to denaturation of your proteins. And so because of that, we worry about it because of, as you can imagine, lots of systemic toxicity. But as kind of discussed with some of our other agents, you do get some localized burns. From that exposure, as well as multi-organ system involvement. Phenol is also known to cause methemoglobinemia, and then it has this clinical finding that's really interesting that's associated with it called Rabbit syndrome, and it's basically these extrapyramidal effects that leads to this very classic movement abnormality that's associated with it that's kind of rabbit-like. So it's called rabbit syndrome. Hexachlorophenol is a phenolic compound that is slightly less toxic than phenol, but we've kind of abandoned using this as well because it had some historical poisonings associated with it. It led to cerebral edema and encephalopathy in some premature babies. If you were to have a phenol exposure, treatment is mainly supportive. Decon is going to be really important here, as we talked about that dermal exposure, so prompt thorough decontamination. This is one where if you do have access to it, some other solvents might be better for decontamination than water. And so low molecular weight polyethylene glycol, mineral oil, olive oil tend to be better for skin decontamination. But if you don't have access to those things, then definitely encouraged to use water because trying to get it off the skin is going to be very, very important. And so lastly, we'll talk about detergents and laundry products. The ones we really worry about are ones that contain cationic surfactants. So cationic surfactants basically cause toxicity because they also denature proteins and cause tissue damage. This is particularly an issue with these products that have highly concentrated cationic surfactants. So Tide Pods, for example. So as we remember the Tide Pod challenge, this is the problem with them because they're very highly concentrated products. They will cause localized tissue injury. They're caustic, but also they can have some systemic symptoms like seizures and metabolic acidosis. Some people have had local airway injury from ingesting laundry pods, so that's something to potentially worry about as well. And so prompt airway management for these patients. Some detergents contain enzymes, and so those enzyme-containing detergents tend to be associated with bronchospasms and asthma. And then for non-ionic or anionic detergents, they will cause mild irritation, but nothing as concerning as those cationic surfactants. And so some study tips for you is to know the toxicity profile of some of those specific toxic alcohols that we talked about. So methanol with blindness, and ethylene glycol with its association with acute renal failure. Understand the serum ozone gap, memorize the formula the night before your exam, but also understand the limitations with applying the osmolar gap. Know when you need to treat with fomepizole, and that's when you have any parent compound available. But hemodialysis is also indicated in certain cases where the concentration is very, very high. And so you want to clear some of the parent compound because of that. Or if you already have a metabolic acidosis, you're going to need hemodialysis to clear that toxic metabolite. So all of the household products that we discussed are caustic to some degree, and they tend to blend into each other because of their tendency to cause multi-organ system effects. And so my tip for that is to try to remember something unique about each of them. So like phenol with the dermal absorption, or iodine with the thyroid dysfunction. And so that is all I have for you. Thank you so much for your time, and good luck with your exam.